Hi, welcome everyone. It's so incredible to have so many of you joining us, and thank you for being here today. My name is Greenberg. I am the team co-coordinator for Right to Health Action, along with John Schaefer. I previously worked in access to medicines, organizing before returning to school as a medical student at SUNY Downstate, and I'm so appreciative of the diverse, driven, and inspiring community that R2H has brought together over these past few months. Right to Health Action is a grassroots movement of volunteers dedicated to pragmatically fighting for health equity. We came together as a team in response to the COVID-19 pandemic based on a shared belief that health is a human right. We recently held an event to train our community to meet with their members of Congress and advocate for Ruth Bader Ginsburg's seat not to be filled prematurely, and in addition to calling on our representatives to support our People's Pandemic Prevention Plan, which we will discuss later today. We believe that we need to work together across movements to fight for the right to health, and that now more than ever, we need to push for bolder and better policies and must do everything we can to ensure we do not go backwards and have the progress we have already fought so hard for taken away. Today, we will focus on healthcare for all Americans in our current context, including COVID-19, the passing of Ruth Bader Ginsburg, and the impending election. In our effort to lift up existing voices in the movement for health as a human right, Right to Health has partnered with Physicians for a National Health Program to organize today's webinar. This collective space will allow us to reimagine our healthcare system as a more equitable one and take concrete steps towards reforming it. We hope to organize together to not only stop this pandemic and prevent pandemics of the future, but also address the long-standing and equitable American healthcare system that has contributed to the devastating and disparate impact of COVID-19 on marginalized populations here in the US. I want to thank Caitlin Gilbert, Alankrita Sadula, and the entire PNHP team for all of their help in planning this webinar, as well as our many R2H team members who have joined us for multiple meetings to make this event happen. If you're interested in being involved in our community going forward, we'll be following up with information on how that is possible. Before we dive in, let me quickly cover the agenda for today. Following our panel and an audience Q&A, we will invite each of you to join a small group discussion to debrief, highlight points of resonance, and discuss concrete actions we can each take in this very important moment. We have a team of trained small group facilitators who have stepped up to create space for these conversations, and we want to offer a huge thanks to them as well for taking this on. After our small group discussions, we will once again join together as a large group to debrief next steps regarding the actions we hope each of you will elect to take. A couple of notes on technology. All attendees will be muted during the panel discussion, and please stay muted. You can submit questions via the chat at any time. We will refer to these questions during our Q&A following the panel discussion. We are also recording the panel portion of this webinar to be shared within the coming week. After the panel and Q&A, we will share specific instructions surrounding the logistics for moving to smaller group discussions. With that, let me introduce our moderator for today, Rachel Madley. Rachel is a member of the Students for a National Health Program Executive Board, the PNHP New York Metro Board, and is in her 4th year of her PhD at Columbia University. She became engaged in healthcare activism after noticing the gap between the development of a new medication in a lab and the delivery to patients who desperately need it. She is studying microbiology and immunology with the goal of developing new treatments to improve the quality of life of patients. And she herself lives with type 1 diabetes and has firsthand experience struggling to access care and affordable medicines in our current healthcare system. Thank you so much for joining us and moderating today's panel, Rachel. I'll let you go ahead and share a bit more about PNHP, your advocacy journey, and the focus of today's panel. Thank you.
Thanks so much for that introduction. I'm really excited to be moderating this important panel co-hosted by Right to Health and PNHP. So, Physicians for a National Health Program, or PNHP, and our student group, Students for a National Health Program, also known as SNAP, is a 501c3 organization of physicians, medical students, other healthcare professionals, and other healthcare advocates who are advocating and educating for Medicare for all or single-payer healthcare in the United States. If you like what you hear today and you want more info or to join PNHP or SNAP, you can just click on any of the links that are being sent in your chat right now. So I know that COVID-19 has made healthcare one of our top concerns recently, but the fact is that health and healthcare is something that impacts our lives outside of pandemics as well. And today we're going to dive into what we mean when we say improved Medicare for all, universal healthcare, or single-payer healthcare. And as much as this issue is politicized, I think it's really important to also acknowledge that health is deeply personal, because at some point in our lives, we will all be patients and we will all be receiving healthcare. For me, my passion for single-payer healthcare started when I was diagnosed as a type 1 diabetic when I was a teenager. And I'll never forget when I first started to understand the profit-driven nature of our healthcare system. It was right after I was diagnosed. I was admitted to the hospital, and I was told that I could have slipped into a diabetic coma if I had been admitted a couple hours later. So it was an incredibly emotional time for myself and my parents. And a nurse came into the room and let my parents know that they needed to step out to call our insurance company and let them know that I was admitted. Because if they didn't, our insurance company would deny the claim and would not pay for any of my care during that time. And really since then, I have been constantly battling with my health insurance companies to get the care that I need, to get my insulin prescriptions refilled on time, and to be able to see the doctors that I need to see. And I think the worst part about this is I know my experience is not unique in the US, and that many of you likely have similar healthcare horror stories that happened to you or a loved one. And I hope our panel today can demonstrate that we can change our cruel for-profit healthcare system into one that really does provide universal care and puts patient first. So before we get started, I want to ask a few questions to get to know a little bit more about the audience that we have in attendance today. So there will be 3 quick questions for you to answer before we proceed that will be popping up onto your screen, and I'll give you a moment to answer those right now. Great, thank you all for answering those questions. Knowing this information helps us understand who we're reaching and where we could use additional outreach. So now I have the pleasure of introducing our panelists for today's discussion. We're joined by 3 incredible women who have all been leaders for the fight in healthcare for all, each in unique ways. We have Dr. Susan Rogers, who is the PNHP president-elect and assistant professor of medicine at Rush University. We also have Stephanie Kang, who is the health policy advisor for Representative Pramila Jayapal and a doctor of public health candidate at Harvard Chan School of Public Health. And we have Professor Karen Palmer, who is a Canadian independent health policy analyst and health services researcher, and an adjunct professor at Simon Fraser University in British Columbia. Thank you all for joining us, and with that, let's kick things off. So I'd like to start by asking all of our panelists to describe your work and role in single payer advocacy and any personal reason you're involved in this work. And so Stephanie, let's hear from you first.
Sure. Hi, everyone. My name's Stephanie Kang. First, I just want to start off by saying thank you so much, Right to Health and PNHP, for organizing this event. I'm so excited to be on a panel with a lot of the people I work with constantly in Congress to push single payer, Dr. Rogers, Professor Palmer. It's such an honor to be here. Just to let you know how I stumbled upon this work, really, if you had told me a couple years ago that I would be working on Medicare for all in the House, I would have been like, what is that and what are you talking about? And so, my background, I had done a lot and had a lot of experiences centered around health equity, but more through a global health lens. I felt like I wanted to be in global health because I wanted to help address some of the greatest challenges our world was facing. But the more that I was in that work, that was coincided with after 2016 and feeling a lot of despair and feeling like my home was on fire. And, at first I felt pretty hopeless, but then in 2018, we saw this wave of progressive politicians coming into the House. And for the first time, I saw a group of legislators who were fighting for policies that I could believe in, that I could, be excited about. And so I just knew I had to get involved, but I didn't know what that meant. After a lot of Googling, and I just got super lucky, I got accepted into this fellowship for the Congressional Progressive Caucus in the House. And they wanted me to work on Medicare for all. And so basically I arrived a few weeks before we introduced the bill. And we worked really hard with our grassroots partners to construct the most comprehensive, progressive Medicare for all single payer bill that's ever been introduced. And I'll talk more about that later. But I just want to let you guys know, hand in hand with our grassroots partners over this last year, we made sure we got half the Democratic caucus. So that means 119 co-sponsors on the bill, 4 legislative hearings, and all this organizing and events throughout the nation for Medicare for All. So really my work has been about making sure that single payer is a serious policy to be considered and that legislators know why this is the solution for our healthcare system.
Thank you, Stephanie. And we definitely have seen that incredible progress over the past year. Now I'm going to ask if Professor Palmer will give us a description of her role in single payer. I believe you're muted.
Yep, there I am. The mistake. It only took a few seconds. Now we don't have to have that mistake again all morning. Thanks to everybody for organizing this and for inviting me to speak. And I'm happy to join you all on a rainy Saturday in Vancouver. So I've worked in public health since the late 80s. So for much of the 22 years that I lived in the US from 1984 to 2006, I was involved in single payer advocacy in some way. And I would say that I was an accidental advocate, to be honest. My advocacy arose because when I first moved to the United States, I kept hearing how Canadians have no choice in healthcare. And yet my experience was the opposite. I had always had choice in Canada and could see any doctor I wanted, but I had no choice in the US because I was only allowed to see the doctors who participated in my insurance plan. In Canada, I'd never seen the inequity in access to care that I saw in the US. And so I went to graduate school to try and understand this disconnect. And since then, I've worked in public health and in healthcare research and in health policy in the US and in Canada and at the World Health Organization in Geneva. And I've been an advisor or on the board with PNHP for about 20 years.
Thank you so much for joining us. I think your perspective is incredibly valuable to this discussion. And now I'm going to ask if Dr. Rogers will give us a description of her work.
Thank you, Rachel. And again, I go along with my other panelists, just saying how happy I am to be part of this panel and to be part of this movement here. I think this is an incredible idea that we're doing here. But when I was young in the late 60s, that was when a lot of the civil rights activism was very obvious in Chicago, where I grew up, and Dr. King came and marched. And I remember my mother took me and my brother and sister down to one of those marches. And I think that where my activism gene got upregulated, and I became part of who I felt I was. Later, I went to, when I went to medical school, I went to school saying, I'm going to train at Cook County Hospital. And don't do what I did, but that was the only hospital that I ranked when I went in for the match, because that was where I wanted to go. But the thing about working at Cook County Hospital was that it was similar, as close as you can get to a single payer system. At that time, when I saw patients, I never asked them about insurance. It didn't matter. If they needed something done, we ordered it. Now, it may have taken longer, but it still got done. They got great care. Prescriptions were paid for by the hospital. There was never a question whether you can afford your medicine. And then the other part that made it so good too was that the physicians that I worked with, especially in the internal medicine department, all had a similar sense of social justice. I can't say that for all the physicians in the hospital, but at least in a lot of the primary care residencies and those attendings. So it was just a very great way to train, because I so much enjoyed being a clinician, and I feel bad that a lot of you medical students won't enjoy it as much as I did, because you have all this administrative work to do. You have all these boxes to check in your notes, and it's a different landscape for you now, but it was just an enjoyable way to learn and to take care of patients without worrying about the money. And so I went to work for an HMO after that, thinking that that would work, but then our group went bankrupt. But anyway, I ended up coming back to county, and I've been there for almost all of my career, and things have changed. We now have co-pays, we have managed Medicaid, which is really complicated taking care of patients. It's not the same. And it's for that reason, maybe it's nostalgia, but we need to get back to a single payer system, because that is, I know firsthand that that is the best way to do it.
I think those are great points. And thank you all for sharing your perspectives. One thing that jumps out at me is everyone seems to have their own path in getting to healthcare reform and single payer advocacy. And for anyone listening who's newer to single payer, today we're very excited that hopefully this event will be part of your path to that advocacy. So now I'm going to ask if our panelists can tell us, from your perspective in everyday work, what is the current healthcare landscape in your country? And Dr. Rogers, I'm going to ask you to start as a practicing clinician to give us your description.
Well, it's a mess. I mean, I think we all are aware that it's just so fragmented and disjointed that you really, you can't even make sense of it. And there was a quote that I read a couple of days ago from one of the Congress people in this house here in Illinois. And what she said is, we don't have a healthcare system. We have a healthcare industry that functions like a business. And to me, that's one of the most concise statements that describes what we have, because we're not able to take care of patients the way we want. We do what we can based on the financial constraints that patients are put in, which is not always to their benefit. So we have to move on. I think that most of us are aware of the social determinants of health that really impact care. And that's been a big issue with most of the patients that I've taken care of at Cook County, which is now Stroger Hospital. But we just have such a fragmented system with so many players that it's not even run by physicians or medical people. It is, like the representative said, it's an industry. And between hospital groups, health insurance companies, it's just guided by profit. And we just have to get away from that.
Exactly. I think, profit is the #1 priority in our system, and that is absolutely wrong. Now, Stephanie, I'm wondering if you can give us your perspective from your work in the legislature.
Sure. First, I'll probably describe our healthcare system as inequitable, racist, classist, and incredibly expensive. And similar to Dr. Rogers' comments, sometimes we talk about how our healthcare system is broken, but actually it's working exactly the way it's intended to by the vested interests that control the system. And so it's really important to recognize that, because there's a difference between trying to address dysfunction and trying to address the profit motive. There are simply, very powerful interests across the spectrum. And this is not just the insurance industry. This is hospitals. These are provider associations. These are pharmaceutical industries across healthcare who want to keep it the way it is because it's working great for them. And so, I think that our system is definitely dysfunctional to the people it's supposed to serve, but works great for the people who are invested in it.
Exactly. And I think that's crucial to our understanding of how we go about changing it. And Professor Palmer, can you give us your perspective on your healthcare landscape? Because I know you have a very different perspective than Stephanie and Dr. Rogers.
Yeah, so I'll just describe for you how the healthcare system works in Canada, because I do think there's some misunderstanding about how it might work. So Canada has a publicly funded but privately delivered healthcare system in each of the 10 provinces and the 3 territories. And these systems all share features and standards. So most importantly, they cover all medically necessary hospital and physician services based on need and not ability to pay. So that's practically a mantra. And that is in exchange for their share of the federal funds. So to Canadians, this principle of care based on need and not ability to pay is, I would say, it's a defining national value. So because healthcare is constitutionally the jurisdiction of the provinces and territories and not the federal government, each province and territory has one single payer for hospital and physician care. And then beyond that, the majority of Canadians also have employer-based or individual supplemental insurance that covers things that aren't covered under the single payer, like drugs outside of hospital, or dental, or chiropractic, massage, physical therapy, eyeglasses, and a laundry list of other things. There's also publicly funded supplemental benefit plan in each province for people with low income and seniors. And then under most provincial and territorial laws, private insurers are restricted from offering coverage that duplicates what's covered under the publicly funded plan. So private duplicative insurance isn't permitted, but they can compete in the supplementary coverage markets. The federal government's role is mainly to set and administer national principles and to provide funding to the provinces through cash and tax transfers. So long as the provinces abide by the 5 principles of what's called the Canada Health Act, which is federal legislation, they're eligible for the federal transfer payments. And these principles, these 5 principles, are that the plan in each province and territory must be publicly administered, comprehensive, universal, accessible, and portable. And the provincial government's role is mainly cost sharing and health planning to ensure that health services are available through hospitals and private providers.
Thank you so much for that great explanation. And so when we're talking about Medicare for all or single payer healthcare in the US, we're talking about a system similar to the one that Professor Palmer just described. So publicly funded, privately delivered, and that means that you can still go see your doctor as normal, but all of your costs are going to be covered. And the great thing about the legislation, which we'll get into later, is it not only covers medical care, but dental and vision and long-term care and a lot of other services, making it actually the most comprehensive insurance plan that would be offered compared to all of the commercially available plans that we have in the US. And so I'd like to move to our next question, which will talk a little bit more about single payer. So what are the biggest myths or misconceptions about single payer that are circulated by the opposition? And Professor Palmer, I'm gonna ask you to start.
So one big myth I recently heard is that the government decides my health care. There is no government in the room with my doctor and me. That space is sacred. Never in Canada have I felt that the government intrude in my personal health care. I cannot say the same is true in the US, where when I lived there, I regularly felt the intrusion of insurance companies in my care. So that's one myth. Another misconception I hear about single payer is that the United States is less homogenous, more racially diverse, some say, and therefore too difficult to roll out Medicare for all. But here's the truth. Canada is a racially, ethnically, culturally diverse country. It is a myth to think that we are all white. About 73% of Canadians identify as European white as compared to 72% in the United States. In Canada, 6% identify as Aboriginal as compared to 1% Native American in the US. That leaves 21% as visible minorities or people of color in Canada as compared to 27% in the States. So both Canada and the United States have about the same percentage of people who identify as white and the same percentage who do not. Here we have a larger population of Aboriginal people, South Asians, Chinese, and a smaller population of Black than you do in the United States. Vancouver, where I live, is even more diverse. Here we are only 49% European white. 51% of us are East Asian, South Asian, Aboriginal, Middle Eastern, Latin American, or Black. So it is just not true that diverse nations like the US can't have single payer because, and beyond that, why would you want to deny care to anybody? Whether you're rich or poor or Black or white, it shouldn't matter. Health is the starting point for our potential as human beings and as nations, and without fair access to healthcare, we can't optimize health. It underpins everything. So those are two myths that I have most recently heard and have also heard over the years.
Thank you. I think your lived experience in the Canadian system is very great for us to hear when we are confronted with those myths from the opposition. Mm-hmm. So now I'm going to ask if Dr. Rogers can share some of the biggest myths that she's heard about single payer and possibly myths about how it would affect physicians and healthcare providers. I think you're muted, Dr. Rogers.
Sorry about that. There are so many myths, and I think that just makes it clear that so many people don't understand what single payer is and why it would be such a benefit. A big myth is that we can't pay for it. And even though we're paying more in government money, a lot of people think that it's all employers who pay the bulk of it, but it's really the government that is paying the bulk of what we spend on healthcare. And even if we started with a tax, it would actually be less than what people are paying for their employer-based premium. And then that tax would more than cover what we spend, would more than cover what it would cost to cover everyone. We wouldn't have to pay for these huge administrative costs that really take so much of the money that we put into the healthcare system. The insurance companies, the hospitals, because right now they place resources where they are able to make money versus where they can provide needed care. And this is why so many people are not able to get the care they need. We have such stark inequities in this country. The other thing too is, I think Dr. Palmer, you referred to the government would control, but I think that one of the things that I think providers are now beginning to see is that they are being controlled by private insurance companies and hospitals. They're forced to discharge patients earlier than they want because the hospitals want them to get patients out of the hospital. They spend so much time on administrative coding and work and checking boxes, the pay for performance rules that actually harm hospitals that do take care of poor patients, and it actually penalizes those hospitals. So we have a system that isn't working now, and what people don't realize is that the reason why is not the myth that they think, that it's because of the financing that we have in this country. And one other thing too is that a lot of people will say the government can't do anything right. But one of the things that was written when Truman first proposed universal health care in this country, and his goal was to get all people covered, one of the things that, was the counter argument against him was that this was socialism. And I have heard that argument from so many people, but even when you ask them, well, what do you mean by socialism? They have no idea. They can't even define socialism. Now, the VA is a system that is socialist by definition, but the rest of the system here is not socialist, and it would not be socialist at all, because it would be, like you mentioned, Rachel, government funded, privately delivered. And we would then be able to deliver it the way we wanted, because we would make the choices. It wouldn't be the government deciding or a private insurance company deciding what care gets provided.
Great, thank you. And now, Stephanie, do you have other single payer myths that you often hear?
Oh, there's so many, but I'll pick the top two that I hear. One is this illusion about choice, right? And Professor Palmer touched on this in her introduction. But all of the Partnership for America Healthcare ads that I've seen, which is this dark money group of like pharma and insurance companies and hospital associations, they put out these ads that say, the Medicare for All would take away your choice. You won't be able to see your doctor, you'll lose your plan, etc. But I think COVID-19 has made really clear, what choice do we have in this system, right? Every other industrialized country in the world recognized you simply cannot tie healthcare to something as transient as employment. You just have to guarantee it no matter what your status, employment, immigration, regardless of who you are, it should be guaranteed. That's just the underlying notion that you need for a thriving society. And so no one I've heard lately is making the argument that our current employer-based system gives so much choice. Because not only do you not get choice if you lose your job, meaning you lose your health care, but 25% of employer-sponsored plans are considered to be underinsured. So even when you have your plan, you don't have much choice to begin with. The second thing I'll touch on, I'll try to be brief, but it's a big question, is how do we pay for it? How can we afford it? And what I want to make super clear is just how expensive our system is. I think people don't realize how much we spend on healthcare. We spend at least 18% of our GDP, more than twice per capita than every other country. And both Dr. Rogers and Professor Palmer have touched on the reasons why. Our high administrative costs, all the billing, the profit motive, and also our drug prices. Medicare and Medicaid are the largest purchaser of drugs in the world. And yet they're not allowed to negotiate drug prices. Medicare is not allowed to negotiate drug prices. And I'm sure everyone can guess why. It's because pharmaceutical companies lobbied and made sure that there was a clause specifically stating in the drug bill saying Medicare, the federal government, cannot negotiate drug prices, right? And therefore, we pay on average 2 times more on drug prices and sometimes 10 times more for drugs like insulin than, you know, our neighboring country, Canada. And so when people say we can't afford it, we are already paying more for this expensive system that doesn't cover everyone than what Medicare for all costs. The last thing I'll say is that there's this great study from UCSF that analyzed about 22 analyses of single payer costs. And they concluded, didn't matter what the political leaning was of the economist or the analyst, they concluded that every single study showed that a Medicare for all system, a single payer system, would cost less than our current system within the first year. And so we're already paying for it. It's just our money is going towards private insurance premiums. And so instead of money going there, why not put it towards a government premium that's going to then guarantee everyone has healthcare?
Great. I think all of those myths and working to really debunk them is very important for this movement. And so if you have heard any myths or have any questions about single payer that you didn't hear touched on yet, feel free to throw it in the chat and we will get to some audience questions later on. So now I'm going to turn our focus to COVID-19, which has been a very big part of healthcare these past few months. And I'm going to ask our panelists to describe how you think the health system in your country responded to COVID-19. And Dr. Rogers, I'm going to ask if you'll start off with this question.
Well, clearly our government has not responded well. Any pandemic needs a coordinated national response, which we did not have under, no matter how you look at it. One of the things is that the inequities that it really laid bare, these inequities have been there for years, but they've been ignored and people have tried to pretend that they didn't exist, or they tried to blame the victims. We do that a lot in this country, that you have this illness because you don't eat well, or if you exercise more, you wouldn't, have this or that. And it's not the victim's fault. I think a lot of the inequities that COVID really laid bare are a reflection of the structural racism in this country that has created the social determinants of health that really impact on people of color and minority communities. I mean, you can't get away from that. And that's why healthcare is such a big piece of this whole big soup, this whole stew that has all these social determinants of health, and at lack of access to that too. So it's not that for some reason immigrants and people of color had more diabetes or COPD. It was because of these social determinants of health that created those underlying comorbidities. It wasn't anything innate in those people. It's a reflection of where they live. So what COVID has shown is it's just shown all the inequities that are here in this country. And that that it is important that because this is a communicable disease, that everybody needs to be treated. But we should feel like that even without a pandemic. Everyone needs to be healthy. You want to know who's cooking your food when you go to a restaurant. You want to know who's sitting behind you on the bus if you're riding a bus. So it's to everyone's benefit that we are all healthy. And I would hope that we could see that learn that from this pandemic. But unfortunately, I think we're not learning that. But I think that should be the biggest takeaway that we take from this pandemic, is that we all need to be healthy.
I think that's a great point, and the disparities it's bringing to light, I agree with you, are crazy, and we should have addressed them far before this pandemic ever occurred. Now, I'm going to ask if Stephanie can give her perspective on how the health system in the US has responded to COVID-19.
Sure. I think about this often because my family is from South Korea, and they have TV shows from South Korea broadcasting all the time, nonstop in our house. And they have a lot of, TV shows that are, literally filmed the week before. So these are current. And you see people outside in like a regular society with businesses open and people able to just continue their day and go grocery shopping without concern. And the reason, and it's interesting, right? It's such a stark contrast to a lot of the situations that we've been in terms of our lockdowns and the, sort of cultural environment that we've had for COVID-19. I mean, one, COVID-19 has just become incredibly politicized, where that simply just wasn't something that, other industrialized countries had to deal with. But second, even after 9 months, right? 9 months of our first COVID-19 case, 8 months, we still don't have a national testing strategy. We still don't have a national contact tracing strategy. We still don't have the basic fundamental things that you need for any pandemic response. It's just like it's like textbook pandemic response 101. And the reason why that is our system is so fragmented. We have not a coordinated system like single payer systems provide us. And Professor Palmer has a great, explanation of how this has been seen in Canada. But, you have that on top of this crippling health insecurity that so many people are experiencing, right? Even for people who are insured, when I mentioned that they're losing their jobs, that's their healthcare. But even if they've been able to maintain their insurance, we're seeing people who have been diagnosed with COVID and after they survive get $30,000 hospital bills for receiving COVID-19 treatment, even though supposedly it's supposed to be covered. Right? But private insurance companies are sneaky and they can find different ways to be able to bill it. They're not going to, so they don't have to cover it because it's expensive. And so we're just seeing all of these unnecessary issues that simply other single payer countries have not had to experience. And the last thing I'll say is, South Korea and the US had their first case of COVID on the same day. And yet in Korea, it's about 2 cases and deaths per capita. Ours is 197. So
I think that's a great point. And I mean, I've even seen the testing numbers early on from South Korea and the US, and we were just so far behind. And, as a scientist, it's mind-boggling how we let it get this bad. And so, Professor Palmer, I'm wondering if you can give us your perspective being in Canada on how that healthcare system has responded.
I can do that. I just want to say that I've been at this for a really long time and I get excited listening to Stephanie. So one of the biggest strengths of our response in Canada has been through our healthcare system. So people have not delayed care because they're worried about the cost of care. If you get sick, no one in Canada lacks access to hospital or physician care. If you think you have COVID, you get care. For any care you get from a physician or a hospital, we don't have co-pays. There'll be no deductible. There's no co-insurance because those things don't exist here. As always in Canada, always care is free at the point of service. Then because our hospitals are all publicly funded, there has been an impetus for hospitals to work together. People are thinking across sectors, across boundaries to take care of communities because the single payer enables that kind of cooperation. All kinds of decisions are being made at the regional level. For example, which hospitals have COVID assessment centers, which ones have increased ICU capacity, which surgeries will move from one hospital to another to liberate resources. That's all decided regionally. So when you have a single payer, you have a system you can work with collaboratively. And without that, it's just harder. I'll just add that underpinning how our healthcare system responded is the fact that our initial pandemic response in Canada wasn't politicized. There was a high degree of cooperation across parties, and major legislative initiatives found their way before Parliament. We were Team Canada. Now we're starting to see a more active and vocal opposition to some aspects of our response to COVID. The Conservative government the other day called on the Liberals for greater focus on jobs and fair trade. And so this wrangling is, more consistent with the traditional accountability that is familiar to our democracy. And that's also welcome. I'll stop there.
Great, thank you. And I want to make sure we leave enough time for audience Q&A. So I'm going to ask the panelists if they can just quickly describe any long-term effects on our health system from the COVID-19 pandemic, if there are any that stick out in your mind. So Dr. Rogers, would you be able to start?
Well, I think we are seeing more hospital closures, for one. Larger institutions that see a lot of privately insured patients are doing well because they have a safety net. They have a huge amount of money that they're sitting on that can cover their loss of expenses that happen when they stop doing elective cases. But there's a lot of communities where there is not a hospital, or the hospital that is there is really teetering on the edge of bankruptcy. Even here in Chicago, on the south side of Chicago, there's an institution that's been here for 150 years that will close in January for that very reason. Their revenue is not enough. So I think that what has happened is that it has now been, what's going to I think float to the top is it'll be the survival of the fattest and not survival of the fittest. And it's going to leave a lot of communities and people without access to any care because communities have now become medical deserts.
I think that's a great point. And, you know, that is one of the things that is scaring me about the pandemic is that our health system is going to be even more broken afterwards. Stephanie, do you have any long-term effects in mind?
Sure, I have two. One is we're still not quite sure what the long-term effects of COVID-19 is on health, right? So if somebody has COVID-19 and they survive, we're seeing that there's this large range of very detrimental effects that can happen on the cardiovascular system, the respiratory system, immune system. And, you know, we might have a population that is ultimately sicker. And, you know, if you can contrast that to, you know, the insurance system that we have now, we're going to have a lot more people that are going to need healthcare, and yet they might not be able to access the care they need. So that's one. And the other piece is really thinking too about the economics, which I think is just absolutely interlinked with the health system. You know, we have over 80,000 small businesses that have shut down. And this is going to, again, healthcare is tied to employment. This has created a huge shift in where people are able to get their healthcare. And so we're going to see that it's going to take a long time for people to recover. And at the same time, they're facing this health insecurity because of our current system.
Exactly. I think those are all really important considerations for moving forward after this pandemic. And Professor Palmer, do you have any long-term effects that you see on Canada's system, or are they more insulated from those?
No, I can give you three. I think that there is opportunity to be found in adversity. So one of the effects will be changes to our long-term care. So Canada's long-term care sector has been especially hard hit by the pandemic. 95% of our deaths in Canada have been in those age 60 and older, and of those 81% were in long-term care homes. So this, of course, varied across provinces with some worse off than others. But what we know already is that there were more deaths in for-profit long-term care facilities than in not-for-profit long-term care facilities. So there are now big efforts across Canada. I've been on several webinars to better protect people living in long-term care and other congregate settings. Another effect is the shift to virtual care will continue. The pandemic has forced the entire healthcare system really to rethink how we deliver care. So we had a nearly overnight shift to virtual care, dramatically increasing virtual visits. In a relatively short time period, teams quickly deployed digital health tools and new virtual models of care to help patients. So I'll just give one example. At Women's College Hospital in Toronto, on the other side of the country, within a 2-week period, nearly 80% of patient visits at family practice were conducted virtually. Women's also launched something called COVID Care at Home, using digital pathways and tools for primary care providers to virtually support patients with COVID at home. So about 85% of all services at Women's now are virtual. So the pandemic created an opportunity to rapidly adopt virtual care, which of course had been under discussion, but there were all sorts of reasons why it wasn't possible. And then within 2 weeks we had it. And so I think that will continue to expand into the future. And the last point will be, I think another effect is that our supply chains for medical supplies are becoming more domestic. So COVID-19 revealed the vulnerability of our supply chains, including for PPE. Much of our PPE was sourced from China and the United States, and it was front page news in April when the US border officials stopped a shipment of N95 masks headed to Ontario after the Trump administration ordered 3M to stop exporting critical medical supplies abroad. So this, touched off a frenzy of high-level diplomacy so that we could secure an export ban exemption. And as one provincial premier said, we can never, ever be put in the position again that we are relying on countries around the world to support us with PPE. So this incident resulted in the launch of new manufacturing of PPE in Canada.
That's very interesting. I hadn't heard about that specific PPE launch of manufacturing, but I know a lot of countries around the world had to also just start manufacturing their own PPE as quickly as possible. Yeah. So now we're going to shift to the Medicare for All bills that are currently in Congress. And I'm going to ask Stephanie, can you describe what are the current bills for Medicare for All in Congress that are being discussed?
Definitely. And I really can't stress the importance of these kind of webinars that really clarifies exactly what are we talking about when we talk about Medicare for All single payer. Because I think what we saw, especially over the 2020 Democratic primary, presidential primary, was that the name Medicare for All got conflated quite a bit and kind of encompassed this large set of bills that really were not single payer whatsoever. And so just want to be super, super clear that there are not several bills in the House that are Medicare for All. There is only one in the House and one in the Senate. We have, of course, Senator Sanders, who is the champion of the Medicare for All bill in the Senate. And then we have the Representative Jayapal of Washington 7th District. She's the chair of the Congressional Progressive Caucus. And her, along with Representative Debbie Dingell, introduced H.R. 1384, the Medicare for All Act of 2019. And just to give you a quick rundown of what it is, basically what it does is that it takes Medicare, which we know a lot of seniors love, but needs a lot of fixes. I mean, it's woefully under insurance, really, in the terms of the types of benefits it provides. So what it's going to do, it's going to improve Medicare. It's going to improve Medicare to make sure it includes all the benefits that people need to be able to live a dignified life. And so when we talk about health, we're not just talking about our preventive health or primary care health. We're talking about mental health. We're talking about reproductive health. We're talking about substance use treatments. We're talking about long-term care, prescription drugs, dental, vision, hearing, all the things that people need. And then we're going to make sure that it's given with no financial barriers. That means no co-pays, no private insurance premiums, no deductibles. It'll be free at point of service. And then we're going to take this awesome Medicare package and we're going to expand it to everyone. So now it doesn't matter your gender identity, your racial identity, your immigration status, employment status, where you live, you will be now guaranteed from birth the Medicare for All Medicare package with comprehensive benefits. And the other things I want to mention too is that people don't realize this also addresses other parts of the health system. This means no more surprise billing. This means drug prices get to be negotiated. This means that we have better quality control for our hospitals and quality care. And so it's not just about expanding insurance to everyone. It's really about transforming our healthcare system as a whole.
Thank you for that great description. So now my question to the panelists is, why hasn't Medicare for All passed Congress yet? Who is opposing it? Because for me, I mean, sign me up for what Stephanie just described. It sounds amazing, and I'm sure a lot of people or everyone on this call share that thought. So Dr. Rogers, can you kick us off and talk about why hasn't Medicare for All passed and who really is opposing it?
Well, I think a lot of it has to do with the money that gets donated to congressional people, because that affects their vote, and that they refuse to even look at the evidence. They are looking more towards re-election. Even members that you would think would be supportive and other things that they have supported and gotten involved in, that they would support single payer, but they often are, it's like with other issues that the donors come in, the big donors, and that's the big problem is we need campaign reform, because until we do that, we're not going to be able to expect Congress people to act the way they should, because it's become a career, and that's part of the problem. And I don't want to get into term limits, but you know, if you can't do anything else but be a crooked congressman, you have to keep your job, you know. And so this is what's happened, and so that they are blind, and that with a lot of the gerrymandering and all, people who would, you know, vote to support something different, their vote is often diluted. And one of the things I would like to just add about with any single payer system, I think we have to be very, very clear and diligent to make sure that resources are distributed equitably. Because if you look at what happened with public education and after desegregation, even before Betsy DeVos, you know, destroyed public education in this country, things weren't equitable. And that schools in poor communities were never funded as well. And we have to make sure that hospitals in poor communities get funded just as well, that they have the latest MRI or whatever it is, that those things are there, because otherwise the inequality will still remain unless we do our due diligence because of the structure of the system here in this country.
Exactly. And I think it's interesting that you bring up campaign finance reform, because that just goes to show how interwoven this movement is with so many other social justice movements in sometimes obvious ways, but sometimes ways that are not very clear to us on the surface. Now, Professor Palmer, I'm wondering if you can give us your perspective on why we don't have Medicare for all in the US yet.
Well, you know, I think that there are vested interests in ensuring that you don't. I mean, as Stephanie said, the system is working exactly as it was intended to work. And so I think there are, you know, seriously vested interests in making sure that doesn't happen. I mean, we have that influence here as well. You know, there are people who try to undermine our healthcare system. And I think that, you know, that is the struggle.
That's a great point. And I think hearing that sometimes can be discouraging, but I think it's really important that we understand what we're fighting against when we go into this movement, because one thing that inspires me is we have people power. So if we keep building on that, I think we can understand those vested interests and hopefully overcome them. And Stephanie, as someone who works very closely with this legislation and in the legislature, can you give us your perspective on the opposition?
Sure. I have 3 quick points. One, and I mean, first, Dr. Rogers hit the nail on the head. We absolutely have to combine this with campaign finance reform. We have to get the money out of politics. That also shows up in terms of inside the halls of Congress. There are literally armies of doctors who come in their white coats, who come and knock on the doors of every congressional office, and they go and they spout different talking points that they have been trained so well by their association to scare anybody on making any adjustments on health policy. So Medicare for all is undoubtedly, it's an ambitious proposal, but I've seen even much smaller bills like a surprise billing fix get destroyed. Its progress was destroyed. You know why? Because of doctors. But I know that they don't represent the majority of doctors, or at least the doctors that I know personally. And so I know we have a lot of health professionals on this call across the spectrum of healthcare. We need to redefine what lobbying means. We need to redefine what a lobbyist is. All of you can be, and we need to make sure that we match the scale of the efforts they put towards influencing the opinions of staffers and politicians, and also make sure that our opinions and our perspectives and our stories are shared. The other piece is that, you know, of course, we talk about the politicians and the decision makers, but everyone needs to recognize that there's this, you know, entire staff of people who are behind these politicians and actually make hundreds of decisions every day that impact our policies. And, you know, the reality is that, you know, my experience so far on the Hill is that most people, you know, they might have like a political science degree and they go in and, you know, they go up the ladder. They start up as an assistant and then they go into a legislative role and they kind of go up, and they've never had real world experience, especially in healthcare, right? So how are we writing policies on healthcare that impact people if you don't really know what it means? And so we have to make sure that we're actually filling these spaces, right? Not just from the outside, but on the inside. You know, progressive politicians need progressive staffers. We need people who really believe in these policies, championing that on the staff side. Last thing I'll mention is that also the makeup of our Congress is simply not progressive enough. They're not there, right? And that's why we have to make sure that up and down the ballot, we are electing progressives. We're electing people who have had the real lived experience and the reasons why we need a Medicare for all system. And we need to make sure that we change who is representing us in Congress.
Thank you, Stephanie. And I think that point goes right into my final question for the panelists before we get into audience Q&A. How does the current election impact the Medicare for All movement? How do we maintain this movement in our political moment that we find ourselves in? And I'm going to ask if Stephanie will lead us off on this question.
Sure. I think what we have to make really clear is that no progress is possible with Trump in the White House. We cannot underestimate the type of damage that he could do, not only to our healthcare system, but across our entire society. And so we have to make sure that Trump does not win. That being said, you know, obviously our Democratic candidate doesn't support Medicare for all. And that means that as progressive members, we have to hold his feet to the fire. We have to push to the left. Progressive activism isn't just about the result. It's about each little win that you get along the way. And I've been really encouraged, one, because my boss, she served as the co-chair of the Unity Task Force set up by Senator Sanders and VP Biden. And I saw that we were able to push on different areas across policy, push them more to the left. And that was only within a matter of weeks. So imagine what we can do in a matter of 4 years. The other piece is that when we talk about Medicare for all, I mean, it's interesting to me. I'm really encouraged because there are so many competing priorities right now, right? It's really hard for especially Congress members to know where to direct their attention. And even in the midst of this, so many Congress members have stepped forward recently to want to be engaged in the Medicare for all conversation that I had not seen involved before. You know, maybe they supported it a little bit, but it wasn't something that they wanted to engage in and talk about. And so I'm really excited that the fact that there's so many congressional members who are now, I recognize that we have to have this conversation, that we have to engage in this and really think about how do we make this happen. The last thing I'll mention, when we think of Medicare for all, we're not just talking about changing our healthcare system. We're talking about rewriting our social contract that we have in this country. You know, when we think about the civil rights movement, it wasn't just about giving rights to people who deserved it, right? It wasn't just about addressing some parts of racism. It was really about that social contract and redefining what it meant. And so we really have to make sure that, we explain to the other side. I mean, really, it's interesting. 69% of Americans support Medicare for all, according to the most recent poll. That includes 43% of Republicans. I think that number is huge, right? Conversation is changing. The old tropes of socialism and choice and all the other things that people used to say, and that, I don't want to pay for someone else's healthcare, is being challenged. So we have to exacerbate that curiosity that people are having now about Medicare for all, even ones who used to be strongly opposed. So the last thing I'll say is, for all the people who are on this call, I mean, it's really amazing that on a Saturday afternoon, this is what you wanted to do. You wanted to be on a webinar to talk about single payer. I really, it's just so amazing to me. And there's such a variety of people here. And so I would ask you to do a few things. One, go on hr1384congress.gov. I already saw somebody put it in the chat. And look if your congressional member is a co-sponsor of the bill. If they are, awesome. Let them know that you're grateful for that and that you want them to keep fighting for it. It's so hard. I mean, really, the pressure from industry is really hard, and we have to make sure that our co-sponsors become stronger champions. If they're not on it, reach out to them. Right now in the COVID-19 pandemic, We staffers are held captive to our computer. We are constantly on our email and phone. We hear every voicemail. We read every email. We read every letter. So please, please, please reach out to your Congress member. Ask for in-district meetings, because usually nowadays they're home. So there's really no reason, and you can do virtual in-district meetings. It's much easier. So please don't hesitate to do that. And the last thing I'll say is, all of you who are on this call has your own unique story. And I would just, if you're comfortable, I'd ask you to really hone in on how to tell that story. Every person I know either personally has experienced or knows someone who has experienced some sort of healthcare horror story similar to what Rachel had described earlier. And so, becoming better storytellers and better communicators about this topic, really understanding what it means to have a single payer system, why other half measures don't work, will be incredibly important to maintain the movement.
I think those are all great points, and I think all of us on this call have a lot to do to continue fighting for Medicare for all. Dr. Rogers, do you have any other things that we can do to maintain the Medicare for all movement?
I agree with what you said, Stephanie, about that this is just such a vital thing and that our Congress people are just so overwhelmed. And after this election, I'm not sure, regardless of the results of the election, that what the landscape of this country will be. To be honest, I think the right wing, the alt-right, is totally empowered. So regardless of what happens, and I can see where healthcare will just be one of a number of social justice issues that is going to have to be addressed in this country. Over 100 years ago, we had the massacre at Tulsa. We had Rosewood destroyed, all these Black communities that were destroyed. And unfortunately, I can see how that can happen again. And issues like Medicare for all are going to sort of drift back because there's going to be larger, more visible issues that this country is going to be facing, especially immigrants, people of color. I mean, I don't mean to be a pessimist, although I know I sound like, I just think it's very, very frightening what is coming up. And it extends far beyond trying to convince people who are otherwise very intelligent that Medicare for all will work. I think that we are in a very, very scary place.
And Professor Palmer, do you have anything to add to what we can do to continue fighting for this movement?
Yeah, I mean, I think Stephanie and Susan have, beautifully summed up this work, but I will say that in Canada, this was not easy either. In the 60s and 50s, when we were trying to get 40s and 50s and 60s, trying to get universal healthcare in Canada, it was a huge struggle. I mean, in Saskatchewan, where it began, doctors went on strike for 23 days. They imported doctors from England to replace them. There's a wonderful film called Bitter Medicine. It's produced by the National Film Board of Canada. You should be able to find it online, which shows some of the old grainy footage from those days and some of the protests. And it's really worth watching. Because it will inspire you and remind you that, it was a fight in this country and it's worth the fight.
I think that's great to keep in mind as we continue on in this fight. So now I'm going to shift to questions from our audience that people have put in the chat. And I am going to start with a question from Julia Hannabrink. And this question is for Professor Palmer. So the big question I hear from the opposition is concern about increased wait time, especially for elective procedures. What is the best way to respond to those concerns?
So what I do with that is I start with saying there are no waits for acute healthcare in Canada. If you get sick with something acutely, COVID or whatever it is, or any other urgent problem, you get care right away. There are some waits for elective surgeries. Sometimes we call them planned surgeries, just as there are in nearly every other country in the world, including the United States. The difference is that in Canada, our waits are based on how urgently you need care rather than whether you can afford to pay for that care. But the solution to wait times in Canada does not lie in is not the problem of the single payer. How we pay for our healthcare is not what causes the waits. What causes the waits is how we deliver care and how we provide that care. And so that's the big focus in Canada, is changing and improving how we deliver that care and how we organize the delivery of that care. So one of the ways is, for example, a single queue. So right now, every surgeon keeps their own wait list. Not throughout the country, but in many jurisdictions, every surgeon keeps their own wait. And it would make so much more sense to, as we have done in some parts of the country, to have just a single wait list, a single queue, so that you go to the next available surgeon. And if you don't want to see the next available surgeon, then you can wait for the preferred surgeon. If your neighbor says that you have to see Dr. X and Dr. X is the only one, that's fine. You can wait for Dr. X. Dr. X may have a longer wait. But this notion of moving people through the system quicker, through how we deliver care is how I respond to the question of waits. But our waits have nothing to do with how we pay. They have to do with how we provide.
I think that's great insight, and another one of those myths that we often hear. Now I have a question from Hannah Lichstein for Dr. Rogers. Are there any state level interventions that you see as being helpful? Knowing that true universal healthcare must be national, how can we advocate and make change locally?
Well, working in the state at the state level creates some financing issues, mainly because if you look at Medicaid is a state funded program that can work rather well. It does have its issues, but it's still dependent on federal money. And currently, most states do not have a way to pay. You can correct me, Stephanie, because you probably know more about this than I do, about state funding and government funding and all. But states may not have a way on their own to pay for the health care of their entire state without federal monies. And that was an issue in Vermont, and it's been an issue with trying to galvanize the momentum to do that, to develop their own state. However, it's trying to work, but the problem with it, and I know that in Canada, it started province by province, but we have so many more states that to go state by state would make it probably a little bit more difficult for it to become national. And all the savings come from it being national. And so that's where the real benefit comes. So it's not that getting a state to do it is not good, but the benefit to the country comes from a federally funded program.
Stephanie, do you have anything you'd like to add in terms of the state question?
Sure. Dr. Rogers summarized it really well. The financing is an issue, and that's why there's a state-based universal health care bill in the House. It's been introduced by Representative Ro Khanna. And what it does is that it creates waivers so that states can apply for that extra federal funding and that investment that they need to be able to finance that system. But it's undoubtable. A state-based single payer system is going to face different political challenges. But this is a bill, the state-based universal healthcare bill, and accessing federal funds for universal healthcare systems in the states. It's actually a point that was discussed in our negotiations with Vice President Biden, and something that he agreed to. It's actually on the list of recommendations that his campaign agreed to. So in that next Congress, if we have a Biden administration, it's something that we'll have to hold his feet to the fire and remind him to allow states to access this funding if they are ready.
I think that is a very exciting development. Oh, Dr. Rogers, go ahead.
Yeah, can I just make a comment on the wait time issue, and that one of the things that even if there is availability somewhere else, a lot of communities have issues with transportation. Women have issues with childcare, so that with people of color and poor communities, traveling may not really be a feasible response to that, because they have no way to travel. Transportation in poor communities is often inadequate. The safety issue is often inadequate. So it's really important that we do have facilities within communities, and it has to be centralized for some specialized thing. Every community does not need a cath lab and bypass surgery. That can be distributed a little bit more widely. But I think that's something we still need to think about, in that we can't have a global approach without recognizing particular issues that certain communities have to deal with. And that's one of the things that still leads to inequities. It's not one size fits all.
Yeah.
Exactly. So I am going to now ask our last question to our panelists, and this is something that I'd like all of the participants to kind of think about as well. So beyond COVID-19, in terms of everyday health, what would single payer mean for people? And I'm going to ask if Dr. Rogers will address this first.
Can you repeat that question? I'm sorry, I was reading a question in the chat.
That's okay. So beyond COVID-19, in terms of everyday health, what would single payer mean for people?
Well, for one thing, it would allow for preventive health, which this country as a whole does very poorly at. It would allow for people to access care when symptoms first begin versus when it becomes intolerable, so that it would just allow all these issues to be dealt with before they become crises. And that is what we see now. There's not everything, but we see in a lot of the population that people wait for too long because they are the barriers from financing, the way we finance, and the barriers that that puts up. Just, you know, people can't avail themselves of adequate care early enough. And so once we eliminate that financial barrier, at least people would feel much better about dealing with issues and not worried about the cost.
I think that's a great point, and just will help everyone kind of think about what would it mean for me as a patient or as a caregiver and things like that. Professor Palmer, do you have anything to add?
So from my perspective, it would mean that people don't have to worry about paying for healthcare if you get sick. It would mean that if you lose your job, you don't lose your main healthcare. It would mean that you don't have to keep a job that you don't like just for the sake of healthcare benefits. It would mean that instead of paying so much for healthcare, you could use that money for something else. And to circle back to where I started, it would mean that you could choose your doctor rather than having an insurance company choose for you.
Those are great points. And Stephanie, do you have anything to add for your perspective on what Medicare for All would mean for people?
Yeah, I guess the best way I could frame this is that, you know, personally, what would Medicare for All mean for me? And I feel like this has shown more prominently for myself over the last few months. But, you know, just to share, my father earlier this year, he had discovered he had a tumor in his spine, and it was starting to impact his ability to walk. But we knew it was going to be very expensive. We knew that it would mean he couldn't work. And so we waited to see if it would improve. Of course, it didn't. And after a few months, he wasn't able to walk anymore, really. His right leg had become almost paralyzed, and we knew we had to do something. And so I was dreading this because I knew his insurance was not great. It's a marketplace plan. And when I looked at the neurosurgeons that were available, there were 4 in the entire state that accepted his insurance. And when I called, 2 of them said they no longer accept it. And so our choices were limited. We found a neurosurgeon, and immediately the neurosurgeon said, we're going to have to do surgery right away. We'll get it through insurance and we'll have your surgery in a few days. I said, oh God, it should be fine, right? I mean, of course, the surgery is like so necessary. The day before the surgery, I get a call saying, I'm so sorry, we're going to have to cancel your surgery because the insurance company denied your medical claim. And I said, so I called the insurance company, and I said much more expletives and vile things than I am right now. But, you know, I said, just like, I want somebody to get on this phone and tell me, how could you have deemed this medically unnecessary? And they said, I'm so sorry, there's nothing we can do. And, you know, they canceled my father's surgery. Luckily, I have, you know, not luckily, it's sad. Sadly, I've heard these stories before, right? And I understood how insurance companies work. And so I was able to advocate for my father and get a physician from the insurance company on the phone. And within seconds, he was like, oh, of course this is medically necessary. We should have the surgery. So it was like, if I didn't push for that, my father may not have gotten the care he needed. And I know I have a lot more agency than a lot of other people do. And so I can't imagine how difficult that situation is for them. And, you know, they had told us if the insurance wasn't able to cover, we could do a $6,000 down payment and $3,000 monthly payments for like a few years. The total bill came out to be $159,000 for his 5-day stay in the ICU and the surgery, and another $59,000 for his rehab center stay for a month. So, I mean, these are all of the things, all of these the story I just explained, it doesn't happen in countries with single payer. And I'm not the only one. I mean, this is just so unfortunately such a common story. And so that's what I think Medicare for All would mean, is that all of that unnecessary burden and stress. I mean, it's medical situations are hard enough. We shouldn't have to deal with that crap on top of it. It's totally unnecessary. And so it just means that people have a real chance at being able to live a healthy life.
Thank you so much for sharing that story with us, Stephanie. And I want to thank all of our panelists today for providing your great insights and different perspectives on what Medicare for All truly means in terms of coverage, in terms of legislation, and in terms of what it would mean for people and patients. Now I'm excited to start the transition to our small group. So I'm going to hand it back to the Right to Health team so we can start that transition.
Hi everyone, my name is Ashwini and I'm an undergraduate student at University of Illinois at Chicago and also a member of the Right to Health Action Planning team for this webinar. I want to start off by giving a huge thank you to our panelists and moderator for a really engaging and riveting discussion, and to all of you for submitting such thoughtful questions. Just to get a read on how everyone is feeling, we're going to launch another quick poll before we proceed. Please take a moment to fill that out now.
Do you want us to fill that out too?
Yes, that would be wonderful.
Why won't it submit?
Keep scrolling down. There's one more question.
Thank you all for your responses. We really appreciate the feedback. I hope that today's discussion has helped you visualize a single payer healthcare system and recognize the dire need for this foundational restructuring to ensure the right to health in times of crisis, such as the COVID-19 pandemic, as well as in times of normalcy. Now, let's discuss some ways in which you all can get involved in this joint effort to protect the right to health and healthcare for all. First, you can learn more about improved Medicare for All and join the PNHP, Physicians for National Healthcare Program, network of thousands of healthcare workers and patients fighting to make single-payer healthcare a reality. You'll find that link in the chat. You can also contact your legislator to support HR 1384 in the House and S 1129 in the Senate. As well, you can also have healthcare conversations with your networks to educate others on what universal healthcare looks like, and we encourage you to continue doing that. This pandemic has highlighted the structural faults in our healthcare system. The People's Pandemic Prevention Plan, or 4P, was created in order to more effectively combat this pandemic and prevent pandemics of the future. Right to Health Action hopes to bring movements together and work in collaboration with other organizations fighting for the right to health, like PNHP. Together, we can revolutionize our healthcare system so that it puts people first rather than profits. The main asks of the People's Pandemic Prevention Plan include, first, investing in global health systems to stop pandemics before they start or spread, including $4 billion for the Global Fund. Second, guaranteeing affordable medicines and vaccines available to everyone and everywhere, especially for products developed with public funds. Third, launching a permanent public health corps of new union workers. And fourth, taking action against climate change and related zoonotic disease transmission in top global hotspots. Now we need your help to ensure that 4P is implemented. we encourage you to join a state-based team of activists to hold meetings with members of Congress and urge them to oppose early appointment to the Supreme Court, which would jeopardize healthcare severely for Americans, as well as to support 4P. You can sign our petition, which you'll find the link for in the chat, calling on Congress and the next president to enact 4P, which already has the support of 250 plus organizations and businesses, as well as over 70,000 individuals across the United States. Aside from these immediate opportunities, we also hope that you will join us for the next portion of this webinar, small group discussions. We are now going to transition over to breakout sessions, where you will be able to reflect on the panel, address any unanswered questions you have, and learn how to help in order to take action to help create a more just and equitable future. In just a moment, you will be pushed automatically into a randomized breakout group with a few other participants, as well as a small group facilitator. This trained facilitator will help guide you through questions that you might have from the discussion. If you have any questions or issues at any point, please use the Ask for Help option via Zoom. Today's small group discussions will last approximately 30 minutes, and we will all regroup around 2:50 p.m. Eastern or 11:50 a.m. Pacific time to conclude. And as you wait to be sent to your breakout rooms, please take a moment to add a key takeaway you had after hearing the panelists speak and/or a major question that you've been left with in our Padlet. You can find the link to the Padlet in the chat as well.
Good afternoon, everyone. I'll be pushing you to your breakout rooms. Please select join room once you see it.
In. Cool. Awesome. Well, maybe this is the group, so we can go ahead and get started. It's really good to see you all. Hey, Allie. So yeah, I'll be the facilitator, small group facilitator for our brief little discussion here at the end of this great event. My name's John Schaefer. I use he, him, his pronouns, and I'm here, because I care about health and human rights a great deal. It comes from my own health challenges as a little kid, and just seeing how challenging it is for people to navigate our healthcare system. But let's do a quick round of introductions. We're going to be using this agenda as kind of structuring our conversation today. So, actually, I can't drop it into the chat, I don't think, because it will go to everybody. But can we go around and just say our names and our pronouns, where you're calling from, and one word that describes your reaction to today's event. And because you have your video on, Dottie, I'm going to go to you first.
Hi, I'm Dottie. I'm in Tucson, Arizona. I've worked in healthcare for 32 years in dentistry. And so I've heard the health history of all of my patients, as well as my own health challenges now. And I've never been able to afford health insurance. So at age 53, I've never been able to afford health insurance despite working as a healthcare provider. It's a travesty. And from what I've learned today, I've been advocating for a single payer. I think the term Medicare for all may be scaring a lot of people off. My suggestion is that we change that terminology. It's a big problem with the DNC, but yeah, I'm galvanizing and feel more empowered by watching this and listening. And I want to be able to share this video because I have many healthcare providers in my family, actually, from nurse practitioners to doctors to pharmacists to nurses, and they don't believe in us. It's the typical answer of, we can't afford it. They're caught in the mire. They're Trump supporters, and I feel very alone. Even amongst just my colleagues, I just feel very, very alone. So this has helped me feel like there are others that share my opinion.
We're here with you, Dottie. Yeah, thanks for that. Really appreciate it. Next up, can we go to Missy? Are you there?
Hi, yes. Nice to be joining everyone. Yeah, my name's Missy Nasser. I use she, her, hers. I live in Philly. I'm a nurse midwife, and I feel very activated.
Great, thanks, Missy. Michelle Monaco, are you there?
Yes. Hi, I'm Michelle, and I'm from New York City, and I found this very stimulating. And I'm on Medicare, but I still have too many things to pay for.
Here. Yeah, work to be done.
Yes.
Improved Medicare for all is improved,
yes.
Underscored. Thanks,
yes.
Michelle. Grateful to you being here. And last but not least, or actually two more, but Dorothy, and then we'll go to Allie. We already heard from Allie, so. Dorothy, are you there? Can you unmute and introduce yourself if you'd like? Oh, that's okay. If you'd like to unmute later and say hi, that would be excellent. But then let's just go to Allie, and then we can jump into our discussion.
Yeah, I'll keep it brief. I'm Allie. I am part of the R2H action team and help to organize this event because I very much believe that, we need to ensure that anyone who needs it has access to life-saving healthcare. I'm a medical student, and a lot of my classmates, and especially my professors, really struggle with believing that this is the right move to protect our patients. So I want to strategize with people who are already in this fight about how we change that. And I feel very hopeful.
Yeah. No, I actually felt a ton of hope as well. I mean, I think, all of the panelists were remarkable. I think, Stephanie just is kind of unbelievable in her clarity of analysis and the way she uses stories from her own experience and those that she's encountered to help, just clarify why this isn't just like an abstract fight, but it's a very concrete one. So I thought that was really interesting. But I thought, one place we could start is just if everyone could share, particular moments or phrases or ideas that stuck with you from this conversation. Just kind of an open question. What were some moments that stood out to you?
Hi, this is Missy. There were a number, but I to just pull out a couple. Susan Rogers, what she said about once we get Medicare for all, like keep bearing in mind how we have to still work. The work continues to make resources equitable, and how much it has to be tailored to each specific community and how important that is. And I really appreciated her comparison with public education. So.
Yeah, that's great. Yeah, I think, the public sector as an entity, a rights, protecting entity is under assault, has been under assault since the mid-1980s. In this country, I mean, it's always been under assault, I guess, in this country, but since the 1980s in particular. And so, I think that the fight to preserve public education and the fight to guarantee quality healthcare services for all Americans, these are deeply connected fights, right? And no, I think that's a really, really great point. Others have anything to add or other points that resonated with them?
Of course, I will say that to hear that dental oral health would be included is huge as a dental professional. I've been, again, preaching this to my patients for 32 years. The whole head seems to be forgotten, the ears, the eyes, and the mouth. are left out. And a lot of people, I think we can reach some of those conservatives if we start telling them, because they call me, I'm a healthcare advocate. I help them sort out their stupid Medicare bill or their insurance denying their implant or whatever. So I think that's an area where we can reach conservatives to try to shift their opinion about this when you start to talk about ears, eyes, and mouth and give accounts and stories. I think that's really important for this organization to focus on. Don't leave that out, because people hear that because they get really upset when their implant costs $5,000 for one tooth. Yeah. And I tell them it's just like a hip replacement, but your hip replacement is $300,000. So there's my point.
Yeah. No, it's a good one.
And I think we need to highlight the oral health, because your mouth is a window to the body. And if your mouth is messed up, so is your digestive system, which is your immune system. And if we don't get that message loud and clear out there now is the time to do it. Now is the time to emphasize, I think, oral health. Thank you.
Yep. No, hell yeah. No, and chronic, dental problems is linked also with heart disease, heart attack and stroke. I mean, chronic infection in the mouth, creates inflammation, which drives, so many chronic health problems. So it's a point that's exactly spot on in my view.
We could prevent so many health problems.
Oh my God, I know. And it's so sad. I mean, you see these huge makeshift kind of dental camps that are set up by philanthropists and people who are doing charitable work to care for people who have massive dental problems and have never maybe even seen a dentist in their lives. I think, it's one of these, inequities that, doesn't always capture the front page news or the headlines, but it's such a deep one. So yeah, I just want to, highlight that. And I think you're right on.
And corporations are buying out dentists because dentists, they graduate, they can't afford to open a practice, so they go work for a corporation. So the same thing that's happening in medicine, where corporations are buying out hospitals, the exact same thing is happening in dentistry, which is why I left the profession since COVID. I'm done. I will not morally or ethically be able to ever be a part of this. I have colleagues who see 22 people a day in those corporate dental offices. I've never seen more than 8 people in my whole career a day. As far as I'm a dental hygienist.
Yep.
That's quality, asepsis, infection control is all not going to be there. So sorry, I just had to say that also.
Well, it sounds like you should be a full-time activist. If I were, maybe that's your next step is doing organizing.
And I refuse to be on
social media is not important. It's connecting with families and friends as you're doing. Allie, I think you had something you wanted to offer up.
Yeah, I mean, I was just gonna, the first thing I thought about before Dottie spoke was just this idea of choice. And I think what she said really speaks to that as well. As practitioners, we don't have a choice in what we end up doing because we are in a ton of debt and we end up going to wherever we think we're going to make the most money, and we don't really get to control the care that we provide our patients. And if we had a different system, I think we could have a lot more control over that as well. And our patients, like Stephanie was saying, only having 4 providers in state and then not even being able to end up going to the one that you thought would be covered, they would have a lot more choice. So I think that word choice has a lot of power. And it's really important to have people like Dottie and all of us from different backgrounds, because we all have a unique perspective about the different benefits of healthcare for all. And I think we really need to be making sure that our politicians are hearing not just about, one reason why, but that there are thousands of reasons why we need these changes.
Great. So I know that that we're hoping to, talk about personal story during this time. Each of us has a story that's brought us here, that's led us to, feel strongly about Medicare for all and single payer and universal health coverage for everybody. And so what I want to try to create space for next is for each of us to share a little bit about ourselves, our own healthcare stories, why, again, we feel so strongly about these sets of issues. And we've heard, glimmers or bits of this already. But let me just start off and just share a little bit about myself. I mean, I remember in 2017, Republicans had been fighting tooth and nail to end the Affordable Care Act. And I was in a basement in a church right off Capitol Hill with a group of rabbis, doctors, priests, patients. And we were talking about what we were about to do. We were listening to a lawyer who was telling us we'd certainly get arrested. We might face misdemeanor, perhaps even a felony. We were about to go and march to the Capitol building to the Senate chamber. We all had tickets to go to the Senate gallery. And it was the day when Mitch McConnell was starting the roll call vote to repeal the Affordable Care Act. And we marched in funeral procession to the Capitol building, got through security, got to the Senate gallery. All 100 US senators were seated right in front of us. Just at the moment when Mitch McConnell went to the dais to call the roll, all of us stood up and screamed, kill the bill, don't kill us. And we kept screaming until we were dragged out and put in, plastic handcuffs and had to spend about 12 hours sitting in a jail cell altogether. But it was a really interesting experience. I mean, I think for me, it like brought me very close to a lot of disability activists, folks who, had experienced, extreme suffering at the hands of our healthcare system. And it, my own interest in this was, because I had had a serious kidney congenital issue that almost killed me when I was 3, and I was able to get reconstructive surgery that paid for it. But my parents had been paying down the medical debt that they incurred from that surgery up until I was out of college. And so it again, like my experience is a small one, but I think the experience of being in that direct action to protect the Affordable Care Act showed me kind of what collective action can do. We'll never know if our action to disrupt the Senate, which is the first time I think the Senate had been disrupted by activists in several decades. But it was a moment that showed me, I think, what collective action can do. So anyway, I just wanted to share that. And give anyone else a chance to share kind of their story as to how you came into this work. I don't know, Allie, do you want to maybe go next? Is that okay?
Yeah, sure. So as I mentioned in my opening, I was particularly focused on access to medicines. I had gotten involved in that in college after going abroad and seeing that, we were having these programs where pre-med students would fundraise a bunch of money to buy a bunch of medicines to bring in basically suitcases and give out for a week and then leave. And I just kind of started wondering, how does this system work where, people are reliant on donations because they can't afford to buy the medications they need themselves or to go to doctors that they would be able to receive care from. And so we have to fill that gap. And I really didn't know very well what the disparities here in the US were, but as I got more and more involved in access to medicines, I started to find out that these issues are not, defined by borders. They're very much prevalent here in the US as well. And it's not at all limited just to the medications that we can afford, but very much to the healthcare that we have in general. And, I started to study these sorts of systems in school, but again, I think like John realized that we can learn and discuss, but ultimately that we need to take collective action to really have any influence over what is happening right now in our country. And so I got involved in similarly a lot of the work to save the ACA. And then more recently, I think, just to highlight why Right to Health feels that this is relevant to our work, COVID has really reinforced again the need for this change. We've seen some policies introduced to ensure that everyone has, testing and care for COVID, but it's not a one disease, one global health emergency issue. It's something that's existed long before and will continue to exist after COVID. And so I think if we can take this moment where people are so upset and so kind of let down by our current government and our current policies, and turn it around and make it an opportunity for improvement. That's what I'm hoping that we can see from this.
Great. Yeah, Missy, Dottie, Michelle, would any of you like to share?
Sure, I can. Oh, go ahead. Go ahead.
Go ahead.
Okay, okay, I'll be quick. I think my focus on this has been for a long time. I've been fortunate myself to have good health, as has most of my family, knock on wood. But I think it started working as a nurse, and then NICU nurse, and then labor and delivery nurse, and then as a midwife. And for me, I'm going to speak broadly, but it's just working for over 2 decades with patients, and primarily in lower resource settings, and seeing the inequities in access and also in outcomes. And for example, in my field, the maternal mortality disparities, just as one example. And so I think for a very long time, I've fought for single payer universal health care, and I tried some, I've been involved somewhat in some state initiatives, which have somewhat seemed like they function well, and some maybe not so much. So I've come in and out of different organizations, also presently a bit with the National Nurses United, that's also fighting for this. So long time commitment, long time, and just the justice work of like, we need to do better. And like we said earlier, I like tying it to other structural issues around inequity and how this country, what we need to improve on. So yeah, anyways.
Appreciate you sharing that, Missy. Thank you. Michelle, I think you were going to go next.
Okay. Yes. I mean, I just believe so much that we have to have Medicare, health care for all. I can't believe that we have a country where people can't get their health care. And so I'm just a big advocate of trying to see this happen. And I'm back again to my Medicare. I had an operation and I'm still paying for that hospital bill and all the side things that went with it. They stopped paying for ultrasounds, which I could not believe. And I had to have many ultrasounds. And so I have to pay for those. And then we're left without dental, which is so critical because as you get older, you have problems with your teeth. And now I have all these problems with my gums and my teeth, and I don't know what they're going to do, but I have to rely on my daughter and son-in-law to help me pay for this. So I feel very guilty.
So yeah, I'm really sorry to hear that, Michelle, and it's really unfair and unacceptable. It's so sad and unfortunate that you had to go through that, and that so many millions of Americans have to go through these kinds of challenges. But thank you for sharing that and for being here.
You're welcome.
Yeah. Dottie or Dorothy, would either of you like to share as well?
I think I've said, I don't want to repeat what I've said earlier, but a point that was brought up that I hear resistance from people when I try to share the concept of a single payer is they don't want their taxes paying for illegal immigrants. I wonder if anyone here or you can address that issue, because how do we explain that one away? How to be a humanitarian? I can respect their point of view, but at the same time, I lived in New Zealand. I was legal and I had a work permit and I had an appendicitis attack and a broken ankle and I never paid a dime. It was fantastic.
Yeah.
So, how can we address that matter?
Yeah.
Paying for people who aren't supposed to be here. However, many of them have been here picking our fruit, our vegetables,
Yeah.
feeding us all our lives. And we don't
Yeah.
even realize that they've been here for decades, and why we haven't just fast tracked them so that they, and they may pay tax, but because they're not citizens or residents, they don't get any of this coverage.
Yeah. No, I think it's a deep, deep question. I mean, so during the day when I'm not doing organizing work with Allie, I work to study sociology, and sociologists have a lot of thoughts about immigration. But my kind of read on this is that the kind of immigration crisis is really one of, as you alluded to, Dottie, labor exploitation. And at the end of the day, this is about creating precarious people in precarious positions so that they can be easily paid living wages to do dangerous, difficult work that people otherwise would not want to do. And so it creates precarity such that labor can be cheap and prices can be low, and gets us cheap vegetables and fruits, gets us cheap domestic labor, gets us cheap, run down the list of labor and work that folks would rather not do. And so, I mean, that's the deep point. I mean, I don't know if that's going to sell very many conservatives on the puzzle that you present. I mean, I think one thing that is a sort of easy one, which was alluded to and brought up during the panel, is this idea that, does it really make you feel safer when the person riding the subway or in the grocery store might have tuberculosis or COVID-19, or, that we actually have a lot of shared value and benefit in ensuring the people next to us and around us have care for all sorts of infectious diseases. I think the second thing that I think ought to appeal to, a conservative mind, although again, we see, all the ways that these things get bent and twisted, is that at the end of the day, we still pay for it. It's still in the price tag. People show up in the emergency room dying of a giant abscess filled with pus and infection untreated. They're going to have surgery to deal with that. Those bills won't get paid, and then the hospital eats the cost. And then guess what happens? They overcharge all the insurance companies in order to recoup those costs, in order to keep their bottom line intact. So the price is already there. It's already being paid for. And we make ourselves more vulnerable and at risk by not ensuring coverage to everybody. So I don't know, those are two self-interested arguments that, again, I mean, I also feel those, but I also think that, humans ought to live with decency and dignity. But if that doesn't motivate you, at least, the fact that we're paying for it and it makes us more at risk, maybe would, I don't know.
Yeah, I think, there's also just those people who you're maybe not going to convince the people who don't care about the moral kind of aspects of this. But what we can do is convince the people who are labor advocates, who are, trying to fight for immigration rights, and say we all need to be part of this fight for universal health care, because the people that you are fighting for need that as well. And it's not just a health advocate issue, it's a human rights issue, and we can create collective power by reaching out to organizations who represent other aspects of this conversation.
Yeah, Dottie, what do you think? How does that sit with you, or how do you think that will sit with your friends or the folks you're talking with?
Yeah, those are a couple of good points. Yeah, definitely. That I like the fact that sitting on a bus with somebody who's also unwell, that is a good path into. I hadn't thought of it that way, frankly, until this panel. So yeah, that's a very, very good idea. And Dorothy, if you want to Google my name, or anyone can Google my name, I'm happy to freely in your dental needs.
Cool. So I just saw a message. What did it say? Are we back in a minute? So we
A
have
few minutes, yep.
Oh, a few minutes. Okay, cool. Well, I want to turn a little bit to some kind of more, not that this hasn't been pragmatic, but like some pragmatic sort of calls to action. So obviously we're in the midst of a terrifying electoral season. Where only God knows where this goes and how this ends. But oh wow, we have a minute. A few minutes dropped quickly. So let me just say a couple of things before we close. Vote for Joe Biden. He's our only hope. And then we got to hammer him like hell to break course on what he said. There's no other choice. Come fight me if you disagree. There was some interesting chat earlier. Second thing, we are making huge progress on winning a people's pandemic prevention plan. As was said by Ashwini earlier, but we already have dozens of members of Congress signed on to a Dear Colleague letter authored by Ro Khanna, chair of the Congressional Progressive Caucus, hardcore lefty, and Elizabeth Warren, one of our champions in the Senate. So they're fighting for this pandemic plan. We're trying to get as many signers on this as we possibly can. In the last 2 seconds, join us in
Waiting on everyone to come back.
We'll just wait a minute or so to let everyone trickle back in from the breakout rooms, and then we'll close for today.
I think everyone should be back because,
Okay.
yeah, we got the boot.
So welcome back, everyone. I hope each of you had a meaningful small group experience. Thank you again to all of our wonderful small group facilitators who made this portion of the event possible. In your small groups, each of you discussed points of resonance from the panel and avenues for immediate action. We hope you were able to learn from one another, and that for those of you who are new to this work, you now have additional tools and a network within which to get started. Today, our panelists helped us demystify universal healthcare as we learned about what a single-payer healthcare system could realistically look like in terms of care and cost. Now, more than ever, as our current fractured healthcare system struggles through this pandemic and a Supreme Court justice seat is under the threat of being stolen and given to a conservative, we must take explicit steps to fight for a system-wide strengthening, as well as to end this pandemic and prevent pandemics of the future. The People's Pandemic Prevention Plan outlines necessary policies to ensure we stop COVID-19 from taking even more lives that we do not, and so that we do not end up suffering from the entirely preventable consequences of another pandemic in the future. In addition to the 4 main tenets of the People's Pandemic Prevention Plan outlined before, we will also be asking our congressmen and women to oppose the early appointment to the Supreme Court in order to ensure that the progress we have already won, including access to health care through the Affordable Care Act, is not at risk of being undone. Finally, we will also be working in October to oppose the premature launch of a coronavirus vaccine that would inevitably jeopardize public health and public trust in vaccines. We recognize that the People's Pandemic Prevention Plan, while necessary, is not sufficient, and we will continue to support universal healthcare and collaborate with organizations leading efforts to win healthcare for all. As mentioned previously, we urge each of you to, first, sign our petition in support of the People's Pandemic Prevention Plan, which can be found in the chat, and second, join a state-based team of activists to urge members of Congress to sign on to this plan and other progressive health policies down the line. You can find the links for both of these action items in the chat, as well as in a follow-up email from us after the webinar. I know this is a lot to take in, so we definitely encourage you to take some time to read through our follow-up email, and please feel free to reach out to us via email at info@r2haction.org, or put any questions you have in the chat now, and we will make sure to read them thoroughly and respond to questions in a follow-up email as well. As a group, we're always looking for ways to highlight what is working well and seek out ways in which we might improve. We invite you to share a plus or something that you liked about the webinar and a delta, a point for improvement, as well as one key takeaway from today's event in the chat box. Our team will gather all of these responses for review and try to better inform future endeavors based on your responses. So if you could share a plus, a point of improvement, as well as one key takeaway in the chat box, that would be very appreciated. Thank you so much to everyone for joining us today. We look forward to continuing our work together. And as always, please feel free to visit our website at r2haction.org and follow us on social media for updates on the upcoming webinars and opportunities for action. Please take these last couple minutes to share any thoughts you'd like to share in the chat box, as well as a plus, delta, and takeaway. Thank you so much for joining us today, and we look forward to seeing you all at future events as well.